These are things, situations that you are likely to face. Now, there might be a little bit of repetition from some of the things that you've heard before. Once again, it's anticipate resources, emergencies, and I'll do the C and D again. And I've got a few slides here because I've got a number of cases, probably about 3 or 4, but I'll say 1 or 2 things about the emergencies on the ward, which I think you would probably find helpful. And once again, I think I have heard 1 or 2 people refer to some of these things. Number 1, so what I've got there is, and it may not come up, you might not see much detail. No apologies for that. That's our handover sheet at Chesterfield Hospital. I don't think it's good enough to, if you're coming up 4 o'clock or 5 o'clock, and the person who is handing over to you says, we've got 7 patients and there are no problems. Get some detail. You know, we've got 1 patient acute tonsillitis, absolutely fine, about to go home. 1 is an abscess, been drained, about to go home. The other one is a child with whatever. Get a bit detail. And it's so, so important. So that's what we have here. Get a little bit detail from the person who is handing over to you with respect to what exactly you're dealing with or what you'll be dealing with in whatever shift you're doing. Think about the resources, the team, the people you're working with. So I don't know, you might be doing a locum, you might be a registrar in a hospital where you don't normally work. Who are the nurses working with you? What can they do? Who are the HCAs working with you? Your radiology team, the pathology team. What kind of a call system do you have? Are you directly speaking to the consultant? Is there no consultant on call at all? Have you got 1 registrar who is shared between 3 different hospitals and who just think, what exactly is going on so you have a rough idea of what is. Your IT is so important. Have you got access to PACS? Have you got access to eyes, theatres, prescribing? Can you do all of that stuff? And your hardware, what have you got? And consumables, for epistaxis, do you have silver nitrate sticks? Do you have caltostat? What are the things that you are normally used to? Do you have them in that hospital where you're working? So think about all of those things. Now, if it's a place where you normally work and where you normally know what's there, then it might not be something to think about. But if it's a place that you're not that familiar with, these are very, very important things that you probably should think about before starting a shift. Medical legal issues, safeguarding children and adults is so important. These are things that come up at odd times, and it's not such children, it's also adults. There's a lot of slave trade going on about the place, and you do owe the system a duty to pick up these things once, if you see them. Consent issues can be become an issue in an emergency, and you've got the Mental Capacity Act. When I did this last year, the respect process had just come on in my trust. So can I, with a show of hands, is everybody aware of the respect process? Talking to patients about what they would like in advance. Yeah? No? Bit silent. Is everybody aware of the respect? It should have been on. I'm not surprised to hear that. So this is telling patients about what they would want in advance. I think it's something worth checking. I'm surprised that I can see only just 1 hand. Sorry? A little bit more than that. So DNAR is when you're talking about whether they want to be resuscitated or not. But, it's talking about patients about, do you want to have a tracheostomy? Do you want to have this? Do you want to have that? It's talking about things that they do want to have or don't want to have in the event of an emergency. It's planning for these things ahead of time. Keep up to date, and things have changed. I'm sure I wasn't here listening to your epistaxis talks, but I'm sure that you're all aware that we are very gradually moving away from packing people 10 times to thinking about surgery, particularly when it is indicated quickly. And I've always found it very embarrassing when you've packed a patient and then packed them again and then packed them again 5, 6 times. And then all of a sudden somebody decides that, oh, actually we can do an SPA ligation, and you do the SPA ligation. The patient wakes up the next morning. They probably don't have a pack in their nose, all nice, clean and dry. And what does the patient ask you?
Why do you pack me so many times?
Sorry?
Why do you pack me so many times?
Yeah, why did you park me so many times? So I'm sure, so it's keeping up to date. I'm sure we're moving it gradually away from this idea of doing the same thing twice. If you do the same thing twice, you're likely to get the same results. Think about your new anticoagulants. Different from warfarin, they don't have reversal agents, although if you use them within 2 hours, then personally, I think you can probably use charcoal and things like that. And what do you have a local policy about some of these things, about particularly with the new anticoagulants? One of the things that I've discovered is the steroids. It doesn't come in the 4 milligrams per mil anymore. It now comes in 3.8. And you might just prescribe something, you might prescribe steroids, walk away, and 2 hours you come back and a nurse tells you that, they haven't given it. Why haven't they given it? Because you haven't prescribed the right thing. So, try and be a little bit up to date with things. And batteries, I'm certain somebody must have covered batteries, in the esophagus and ear today. And so it's been up to date with some of these things. So I've got first scenario there. So a 5-year-old has an adenotonsillectomy. The indication was sleep apnea. They returned from the ward at about 5:30, and you're called at 11 p.m. because the child is desaturating. So our pediatric ward is called Nightingale Ward. The child has oxygen saturations of 85%, and that's what you find. Now, unfortunately, it's not very clear, but if you probably just look at the bottom there, you can see that the early warning score, which is the first thing that I look at a lot of the time, is 1, 1, 1, 1, 1, 1, 1. So nothing, go back. Nothing's changed, but things are not particularly very great. So which of these sets of observations would be abnormal for a 5-year-old? And how did you pick out C very quickly? SATs. And yeah, but mainly the SATs, okay? Yeah, good. So that's your chart, okay? And what is important here is the trend. And you can see we're talking about 6 p.m. here all the way up to midnight. Temperature hasn't changed that much, but you can see that the pulse rate is very gradually going up. The respiratory rate is very gradually going up, and SATs, as you can see, are going all the way down. So normal values are important, but probably very, very important is the trend. Either way, if you looked at how can I go back very easily without having to?
Press the left arrow key.
On the keyboard. So that one, okay. And if you look very carefully at that chart, you can actually see that there are the normal values there. Now, this is a very old chart. I'm sure that most of us would work in hospitals where the normal values actually have a nice, it's color-coded, it might be green, it might be whatever, and so your normal value should normally be within there. But whatever the case, the point here is have some way of knowing your normal values, either by looking at the chart, you might have an app on your phone or whatever, have a way of knowing what normal values are. It's so important. Okay, so there we go. And so what do you do? So adenotonsillectomy, they start to drop in, okay? So check the airway. If you've got HDU, transfer them to 1. I would request 1-to-1 nursing. And so important to stop opiates because you never know they might be used. Dexamethasone, the usual dose would be about 0.5 milligrams per kilogram body weight, but you can use up to 1 if there's a big problem. And it's so important to position the child properly if you can. If it's a very small child, that may be difficult. And if you're using oxygen, do so very carefully. And in extreme cases, they might need to be intubated. But one very important thing, and Mr. Duke and I were talking about this just before we came in. Remember, and I don't know where that's here, these situations are usually self-limiting. Why is that? Because the obstructive feature has been removed. So most of the time they're self-limiting. Most of the time you shouldn't have to go as far as intubating them. They're usually self-limiting because you've actually removed the problem. Well, if you've done the operation properly. Okay. And what are the key points here? There is a small but significant risk of increased of respiratory distress after surgery for obstructive sleep apnea. Does anybody know what could have been done better here? I don't know whether I should go back. So I'll go back. Sorry? Well, okay, that's an interesting one that you raised. Who should be nursed on HDU? Everybody?
If they have severe sleep apnea, they probably should be re-evaluated in a pre-assessment clinic.
So yes, and what are you checking for in a pre-op assessment clinic?
They've got a sleep study with a documented.
Okay, so sleep study, some people don't do it, but yes, sleep study, I think it's a great thing to do sleep studies because if they've got severe sleep apnea, those are the ones most likely to get problems. But what are the things so in my world, I am looking for patients who've got comorbidities, patients who've got maxillofacial problems. These are the ones who are more likely, got neurological problems. These are the ones more likely to cause problems. So yes, that's what else could we have done better here? Where do you want these patients on the list? First, second, third, fourth, fifth? First. Okay, so obviously this patient wasn't done first because if they were done first, they wouldn't have been coming back to the ward at 5:30. So that's another thing that we could have done better here. So, and I'll just quickly go back to my... so what could we have done better? So operate on them first in the morning, experience anaesthetist, no opiates, and for people who are doing exams, remember that there's some patients who metabolize codeine to morphine very quickly, and that just causes respiratory depression. It's not common at all, but in Afro-Caribbean patients of Asian origin or patients from Middle East, they're more likely to have these problems. Okay, and anticipate HDU and I didn't know that this at the Children's Hospital. I don't think all these patients need to be admitted onto the HDU except they have comorbidities. Should they be done as day cases? Yes, if it's mild, yes. And I'll one or two of the slides afterwards, we'll talk about which ones and operate on patients that you can cope with. There's a big trend in this region. A lot of these patients get transferred to the Children's Hospital. So day cases, which ones are not appropriate for day cases? If they got severe sleep apnea, I think you want to think very carefully about that. If they're very small children, and if they've got all those comorbidities, and these are things you may not commonly see, but I probably wouldn't want to do patients like this as a day case because you're more likely going to end up with problems. Bleeding diastasis, if that's established before you did the operation, you definitely don't want to do them as a day case. And patients who, and in this last group, you wouldn't be able to plan or anticipate this, but patients who wake up with a difficulty while you're waking them up from the anesthetic. Okay, and which ones can you do as a day case? So it's just your normal day case criteria. I think these people, and if they've got mild sleep apnea, mild moderate sleep apnea, they should be fine if they haven't got any other problems and they fill your standard day case criteria. Okay, so next scenario is a percutaneous tracheostomy. Show of hands, and I need to wear my glasses so I can see hands. How many people have done, this is June, how many people have done at least 6 tracheostomies in ITU patients this year? 6. Okay, that's good. Just 2. Okay, 4, 2. Okay, so I'm sure the numbers would have been much more than this 15 years ago. Do we all agree? Yeah, and we all know why. Percutaneous tracheostomies. Okay, so they become commoner and commoner. They're brilliant. You don't have to take patients to theatre. Operating time is quicker, improved cosmetic results. You've got a smaller wound, so you're likely to get less wound infection. But things don't always go well with them. So you're on call, and you're called to see this gentleman who's had a percutaneous tracheostomy 6 weeks ago. Sorry, 6 hours, 6 hours ago. The nurses noted that his dressings were getting stained, and they kept changing them, but now they felt, well, they need to call somebody. So, first thoughts, what vessel is likely to be the likely culprit here? Sorry? Okay, that's interesting. You said anterior jugular vein. So the anterior, how many anterior jugular veins do we normally have, roughly? So either 2 on each side or 1 on each side, yeah? Is it a midline structure? No? Okay. Sorry?
1 on each side.
So it's 1 on each side. So they're usually paramedian, okay? And let's hope that this percutaneous tracheostomy was done in the midline. So I probably wouldn't go for the anterior jugular. Possible, I'm not saying it's not possible, but which other one is likely? Sorry? Inferior thyroid veins, possible. Once again, you know, the lateralized structures. I probably think that the brachiocephalic, if they've gone quite low. Anyway, so you inform the consultant who's on call, who says you should get theatre ready for hemostasis. Which combination below would be the most appropriate thing to do? So we're in an emergency, so we can start eliminating things, yeah? So B is definitely not going to be on our list, yeah? Yeah, okay. Inform your next of kin for consent, yeah, you probably want to do that, but, you know, it's probably not the most important thing you want to do. Reintubate, okay. And remember I've said here, sorry? So D, yeah, so you want to make sure they have a coughed tube and, you know, a few things to just get theatre ready. But getting a full blood count, clotting profile, the cough tracheostomy tube should have been in place before now, because that's what they would usually do, and they would change that after about 5-7 days. Okay. Next, one single thing you do to stop this bleeding. What's one single? Now, if you look at this very carefully, a lot of the things on there are very important, but there's one thing that I think. So we're talking about at surgery. What one thing would you do to make sure that you win? Let's assume that the airway is secured with a coughed tube, okay? Because the airway is not the issue here, it's the bleeding. Hopefully, let's assume that that's secured. What one thing would you have to do to make sure that you win? Yeah, okay. So yeah, B, definitely B. There's no question about the fact that you definitely want to open this wound, okay? And obviously making sure that they're well positioned before the operation is also important. And which of these is not a contraindication to percutaneous tracheostomies? Not a contraindication. D, so yes, so okay. And don't forget that obviously a lot of the or contraindications, they may be, you know, sometimes, you know, you might, I'm not aware of anybody doing these in pediatrics. Goiters, definitely you wouldn't find people wanting to do that, and if they've got a neck infection and all of that, they probably won't get to it. So like I said, percutaneous, they've become standard in most of our hospitals. It's unfortunate, it means that there are probably not that many training opportunities for tracheostomies, but it's one thing to think about, that you might have problems with these patients. So last one, so a 28-year-old Derbyshire lady has a total thyroidectomy for Graves' disease. All 4 glands, parathyroid glands, were found in the operation. Both recurrent laryngomas identified in the procedure. Good hemostasis, wound closure. Okay, and you're called to recovery. I thought there was a picture of the lady here, actually. You're called to recovery because you've got 200 mils of blood. I'm sure we all accept that's too much for within hours of the operation. So what do you do? Did somebody say D? B, okay, so check that she's maintaining her airway, check that her drains are working. I'll just quickly say something about drains, so important, and I think I'm getting increasingly distressed. I think many people are not thinking about how important drains are. You know, it's very distressing to get on a ward round and find that, you know, drains either devacked or nobody's picked it up. You know, be familiar with whatever drains you're using. So important. If you're fortunate that you work in a department where drains are not used after thyroid surgery, fantastic, but you definitely would have drains, you know, either with parotid surgery or submandibular gland surgery. So it's so important to be familiar with the drains that you are using. Anyway, so the drains have been emptied by the time you get there. So which of these steps is going to be the least appropriate thing to do? Remember this, you know, so drains are empty, you can see that there's not much there. What would be the least appropriate thing to do? Remember, bleeding's our problem. It's not that she's hoarse or anything. Sorry? So, yeah, so a flexible laryngoscopy is not going to add anything whatever to you do. You definitely want to do all the other things. You might not want to tell theatre about the possibility of a neck exploration, but it's something that you just might want to do. Anyway, so you're called back an hour later, and the bottles are filled again, and neck looks swollen. So obviously things are getting worse. And then you decide to open the neck. What precautions would you want to take? Or, by elimination, what is not important on that list? D. Okay, so okay. Now, so the recurrent laryngeal nerve is important. I'm not quite sure how you're going to deal with parathyroid glands in a situation where there's a lot of bleeding. If you do find them, well, bravo to you. That's fantastic. But your recurrent laryngeal nerve, so in that order, I would say recurrent laryngeal nerve, parathyroid glands, and superior laryngeal nerve are the things that you want to carefully avoid. So post-thyroidectomy bleeds, think about them. Prevention, very meticulous hemostasis. I don't use drains. I think if you do your hemostasis very carefully, apart from the very large goiters, I think most of the time, I think you can get away with using a drain. There's no consensus, however, on the use of drains. Pressure dressings, I go to work in West Africa, and I still see people use pressure dressings. I think they're completely inappropriate. You either use a drain or you do hemostasis very well. And I'm not trying to suggest that if you use a drain, you haven't done hemostasis properly. Investigations are important. Remain with the patient and be ready to decompress the wound. Is everybody aware that the BATS has guidelines for managing patients? I'm not sure there are guidelines. I think it's more advice on what to do with these patients. Is everybody aware? You were going to say something because I know.
But just on the Bates stuff, that Greg Sadler, who's the current president of Bates, had a death. I'm the next president. Most presidents seem to have a death while they're presidents. But he's on the Oxford website. If you just go Scoop, SCOOP, Oxford YouTube, you'll come across a great little video which Greg has put together about just opening up the neck. We now show it to our trainees and our SAS doctors, and only a week ago one of our SAS doctors came to me rather pale on Monday morning, having opened the neck of one of my patients over the weekend, but she'd saved this lady's life, and there's a lot of blood everywhere, but it's getting the pressure out of the neck. And
it's so important.
SCOOP, Oxford, just do that, or Oxford Thyroid YouTube, and you'll come. It's a really good little video on how to.
Yeah, it's great, and so we've used it too since it was presented, and shown to all our recovery staff. We're all now really happy that should they need to in an emergency, they can do it, and it's really great for sort of training all your team. And there's a nice poster that you can stick around the place as well. It's really good.
So brilliant. So if you click on that, and we've got this on the the thing that you can look at the talks later on. If you click on that link, you can get onto the video that Mr. Davis was talking about. And what you've just heard, those two things, in summary, what the BATS has advised. Number one, if you're doing thyroid surgery, you should have some form of protocol on how to deal with these. They're not common, but when they happen, they could really be very bad. That's number two, is what you said, is make sure that anybody who is going to ever to have to deal with these patients is aware of these patients. So your locums, your nurses, anybody at all, everybody must, the general surgery person who is covering, or the neurology SHO who's covering, ENT, or whatever, they must be aware of these guidelines so that they can deal with it very promptly. So important, okay? Anyway, so going on. So this is day one post-op. Calcium's 1.96 post-op, just one calcium, no symptoms, patient not on any medication. Sorry, apart from the typo there. So what one thing must you do? Calcium 1.6. Sorry? Okay, yeah, so now this, to be fair, I'm sure nobody works anywhere where everybody gets corrected calcium, to be fair. So I don't know, and you never have to do calculations like this, I'm sure you, but it's so, and I probably mention it because sometimes you get, they write just the normal the ionized calcium first, and then they write the corrected calcium. So don't forget, always make sure that you're looking at the corrected calcium. So important. Okay, so corrected calcium is now 1.8. Okay, and your patient has symptoms, okay, and appears to be confused, this is quite extreme, I would, and your next step. So just look at these very carefully, because I'm asking for the best answer here. So somebody says with ECG monitoring, do you do ECG monitoring for everybody? Sorry? Sorry? I don't think you need it for everybody. I think if they have digoxin or something like that, it's probably so D. And remember that if they've got symptoms, apart from your one-off first bolus that goes within an hour, you also want to give them another infusion over 24 hours. So important. Okay. So intravenous calcium, I think it's only necessary to do ECG monitoring if they have cardiac drugs on board. And like I said, most importantly is make sure that you give them another infusion over 24 hours. Okay. What are the clinical features of hypocalcaemia? So we're talking about low calcium here, would be of concern. The commonest ones, I'm sure that you've all seen that on the ward. And one thing that you always ask all your patients after a thyroidectomy, have you got tingling around your mouth or on your fingers? So that's something. And then hypocalcaemia, there are loads of symptoms. I don't know whether people do short sex and Trossard signs anymore, but I think a lot of us will routinely check with our patients whether. And the big thing with hypocalcaemia, which I'm sure once again a lot of people are doing, and I'll come to that, is preempting these problems and trying to prevent them. Anyway, so I'll get to that in a bit. So calcium is now 2.0. They have no further symptoms. And what do you do subsequently? Remember, this is somebody who's had symptoms. Continue to monitor serum calcium. Okay. I think if their calcium is above 2.0 and they don't have any symptoms, they should be able to go home. But remember that you want to discharge them on alpha calcidol. Okay. Post-op hypocalcemia can sometimes take days to destabilize. What can you do to predict it? Because that's probably one of the in thing with hypocalcemia these days. I know we talk about trying to prevent it and all of that surgically and everything, but one of the biggest things is trying to prevent it long before it happens. So, what do you think you can do sorry? Most appropriate answer here, because a lot of the things here are actually quite. Sorry, I'm sorry to confuse here. I've actually chosen. I think I'm choosing more than one thing here. I just remembered that. Okay, so. And in recent times, we've started doing PTH before surgery, vitamin D. I can remember several years ago, it wasn't until 2 or 3 days after that we start checking magnesium and their vitamin D. If they're vitamin D deficient before surgery, correct that. Check their PTH before surgery. If they're PTH, and that's going to be on my next slide, I'll probably go through that. And remember that it's not your one-off calcium levels that are important. So your one-off calcium level of 2.2 on the morning after surgery does not mean anything, okay? Because you discharge these patients, they go home, and then 48 hours, they get problems. So you must have some way of detecting these. It may be with a PTH, it may be with a trend if you want to keep the patients in for 48, 72 hours, which I'm sure a lot of us don't want to do, but one-off calcium levels are not terribly helpful. And this is a very scanty flow diagram, I'll completely accept that, but one big thing that you want to do here pre-op is checking vitamin D, checking the magnesium, or PTH. I checked PTH before because I want to compare what it's like before. And like I said, if they're vitamin D deficient, I would replace that as quickly as possible before they have the operation. Very, 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 very important for me is the PTH levels within 6 hours after surgery. And if that is low, they almost certainly are going to have problems. So you might as well start them on treatment, i.e. calcium and alpha calcidol. They're definitely going to have problems. Some people would probably just give everybody treatment. I think that's a bit of an overkill. But whatever you do, I think you should have some way of predicting hypocalcemia and these problems to prevent the morbidity that comes from hypocalcemia.
When you say 65%, your normal level?
Yes. So you want to look at your normal level. I probably just use 50% to be fair. And I would say for most of the patients who are going to have a problem, their PTH will be sky low. Sky low. So I would just compare it to what your initial PTH level was. If it's less than 65% of what your initial was, they're definitely going to have a problem. Drugs, your vitamin D deficiency, if it's severe, that can cause problems. Magnesium deficiency, it's worthwhile checking these things before you get the problems. So key points, like I said, understand your laboratory, anticipate problems before they happen. The trend is important, not just the absolute values. Have some guidelines. It's so important that you have guidelines as to how to manage hypocalcemia. And think about other causes of hypocalcemia, particularly when it's done. I think the other thing to say about this is I think if you're getting into your second or third day with hypocalcemia and you don't seem to be winning, probably even, I'm sure people, probably even earlier, is involving endocrinologists. They're probably quite good with juggling around with these things a lot of the time. That's me, done.